First of all, I would thank the organizers for inviting me to deliver the lecture on novel techniques, modalities in treatment of early lung cancer. So, thank you and good afternoon, everyone. So, coming on to everybody knows primary lung cancer is a leading cause of death in males and female. Lung is most frequent site of metastasis. So, what here is predictive is curative resection can't be feasible when there is advancing age, uncontrolled comorbidities, poor cardiopulmonary reserve because of poor PFT, and refusal to undergo surgery as age advances. So, what is an alternative to surgery? So, image-guided percutaneous ablation in early stage lung cancer, less than 3 centimeters, and oligometastatic lung disease. So, what are the modalities which are available? So, there are 3 modalities which are available. 2 modalities are heat-based ablation and 1 is cold-based ablation. All comes in the group of a thermal ablation. So, thermal ablation is divided into heat-based, that is radiofrequency ablation, that is RFA, and another is a microwave. So, it is similar to how we cook anything in oven or a microwave at the home. It's a similar energy which is used. And cryo ablation is a cryo energy, that is a freezing technology is used. That is a ice ball formation into the patient's body. So this is well accepted with preserving of the lung function as well. So coming on to modalities, that is radiofrequency. What happens is it is widely available and it is a proven with multiple trials which are there. It is reproducible. So whenever there is some residual left behind, we can even do repeat ablation of those things. Coming on to a newer kid is a microwave. It has already proven since a decade. There is uniform zone of ablation. It gives wider ablation margins. There is no heat sink effect. So whenever there is a vessel around the tumor, at that time we use a microwave because there is no heat sink effect. That's the key advantage over our radiofrequency ablation. And it takes much less time as compared to RFA. So time actually is saved in microwave. Coming on to the cryo, it is still newer kid in the block. So what do we do here is it is used generally when it is central lesion, when it is near the tracheobronchial tree, and it is less painful as compared to RFA or microwave where we require mild sedation or small general anesthesia. So what is the principle of ablation is basically destruction of tumor cells by directly applying extreme temperature. So either we use a heat energy which is at least 100 degrees Celsius, or we use a cold energy up to minus 150 degrees Celsius, and we achieve a tumor destruction and achieve the safe margins. So coming on to radiofrequency ablation, so how does it work? So it works like a needle. Needle is placed into the patient's body, and this is connected. The needle is connected to a generator, and this generator is connected to the grounding patch, and this is how the circuit gets completed. So what happens is there is continuous oscillation of ions which happen at the molecular levels, and this oscillation causes heat generation, and due to friction it causes heating of this, and thus causes a coagulative necrosis. So in lung, so RFA, lung is susceptible organ. So many of us would think, since air is not conduction, yes, air is not conduction, but a tumor is conduction. So air acts as an insulator, and the area causes low electrical conductivity, and thus it causes larger volume of tissue which is ablated. So it causes a tumor ablation along with that of the margins. So what is limitation here is it is not recommended when it is a central tumor because of multiple things like large vessel or hilar structures. So this is being overcome by microwave. So microwave also comes into same frequency subset. Here what energy of the spectrum we use is anywhere from 915 megahertz to 2450 megahertz. So what it causes electromagnetic field of dielectric heating. It is much more uniform as compared to RFA. It is less dependent on the tissue. So if it tells at least 6 minutes of ablation, it will finish off in 6 minutes. It does not require time to heat. As in oven, we need to have a preheat time and an oven time. Here, there is no as such mechanism. So there is no grounding pad. That's another advantage because it does not cause burns to the patient. So whenever it is, so what we see here, these are two vessels, and whenever we do RFA, so this area remains under ablated. So this will be residual in case of RFA. When we are doing microwave, it does not have any effect on this heat sink effect. So that's the advantage. Another advantage is that it causes uniform heating. So this blue line is a uniform heating. It maintains sustained temperature as opposed to RFA, which causes continuous up and down of the temperature, and the temperature is significantly higher with microwave. Coming on to the cryoablation, so added advantage is whenever general anesthesia can't be given, cryoablation can be done. So here, what do we do here is a tumor and a safety margin at minus 40 degrees Celsius. It causes cytotoxic cell destruction, which is achieved at minus 20 degrees Celsius. So the added advantage is central hilar lesions can be treated much effectively with the cryoablation. So this is a comparison of RFA microwave cryoablation. So in RFA, electrical energy is used, in microwave, electromagnetic energy is used, and in cryo, either helium-argon combination or liquid nitrogen is used. So depending on which technology we are using, and temperature of RFA is anywhere from 60 to 100 degrees Celsius, whereas microwave would be 60 to 150 degrees Celsius. Whereas in cryo, it is minus 150 degrees. So here, as low as minus 150 degrees Celsius. Zone of ablation is in RFA, it would cover maybe 3 centimeters would be best with RFA. So 3 to 5 centimeters with microwave that's overcome, and you can do ablation as large as 6 centimeters. Cryo, comparatively smaller lesions are ablated. So here in RFA, single electrode is used. In RFA and microwave, both single electrodes is used. In cryo, depending on the size of electrode, depending on the company which we use, 2 to 3 electrodes can be used. So coming on to the advantage, it is RFA is widely available. Everybody knows about this technology because it's there since 2 decades. Microwave, the added advantage is the uniform zone of ablation. Time required is less, no heat sink effect, and larger zone of ablation. And whenever it is near large vessels or perihilar structures, cryoablation is preferred. So whenever there is cardiac pacemaker, RFA is contraindicated, or we need to dismantle the cardiac pacemaker during that time, and that's the advantage of again a microwave and cryoablation. So coming on to patient selection, patient is generally selected in a multidisciplinary tumor board meeting with the help of surgeons, intervention radiologists, pulmonologists, medical oncologists, and radiation oncologists, and this forms the core team of any MDTs. Coming on to the indications for percutaneous ablation. So any inoperable stage 1A non-small cell lung cancer, that is grade 2 evidence, and oligometastatic disease, either it could be colorectal or sarcoma metastasis, or patient who have already undergone surgery and there is recurrence. So that's where there is level 2 evidence. So another alternative indication is multiple or synchronous non-small cell lung cancer. For definitive ablation therapy is the level of evidence is 3. So these are another inoperable pain palliation. So I would not be covering into those details, but that are again the indication. So contraindication is absolute is severe pulmonary emphysema or bullet. So here the chances of pneumothorax or persistent pneumothorax would be higher. That's why it is relatively contraindicated. And life expectancy is less than 3 months. ECOX, that is a performance status. If it is more than 2, and it is small cell lung cancer, non-correctable coagulopathy. Relative would be impaired lung function. However, with RFA and microwave, the lung function is not hampered. I will show in subsequent slide. RFA, again, pacemaker is contraindicated whenever it is near the hilum. There is more chances of injury to those structures. Coming on to pre-procedure evaluation, history, clinical examination, lab parameters, recent imaging is required, which should be less than 4 weeks old. And according to SIR and CRSF, these are two intervention radiology society where lung ablation is considered as high-risk bleeding procedure, and so particular norms need to be taken care where INR and platelets needs to be optimized before the procedure. If they are not, and aspirin clopidogrel needs to be stopped or need to switch over to any low molecular heparin. So coming on to few cases and examples. So this is 71-year-old male with complaints of hemoptysis and has hypertension, diabetes and ischemic heart disease. So this is a lesion around 2.5 centimeters, peripherally located, right upper lobe lesion. So this was a staging PET done, biopsy showed non-small cell lung cancer and tumor mode decision. So patient has poor PFT because of bullae and emphysema, multiple comorbidities. Patient, however, there is no other spread, so was considered as potential curative. So since surgery was out because of comorbidities and poor PFT, also rules of SBRT, so ablation was considered as a plan, and this is how the ablation is carried out. So this was a RFA which was carried out, and there was good zone of ablation, and post normally we do a PET scan day after to see whether a whole area is ablated. So many times there is false impression, but since there is small residual activity, we went in again and did ablation, and there is no residual left behind. So this is a pre-RFA at 6 months. What we see, there is small shrinkage in size, and ultimately there is cavitation or a bullae formation, which is a subsequent course of time. So this is 2-year follow-up, which shows. So this is again a 77-year-old male with persistent cough and diabetes. So this is a small lesion with poor PFT. This is a small right lower lobe lesion, and a biopsy showed non-small cell carcinoma, and ablation is carried out. And this is 4-year follow-up of the patient where it shows cavitation all throughout. So cavitation is for subsequent sequelae for this RFA. So gradually there would be increasing size, and after that it regresses over a period of time, or it forms cavitation. So this is the last case. So again, patient had dual malignancy, HCC, since he was hepatitis B positive, and right lower lobe lesion. This is an adenocarcinoma, 2.7 centimeters nodule in the lower lobe. So how do we perform it? So this is a PET scan of the earlier patient. So we do it under CT scan guidance. And this is how we mark on the CT scan and see which needle is corresponding to the lesion, and accordingly we enter the nodule, and after entering the nodule we generally prefer the coaxial needle and multi-pronged needle if we are using RFA, and that's how the multi-pronged electrode is used. And then after so this is, we check it in all 3 planes whether the whole lesion is covered appropriately. Along with that, at least 0.5 to 1 centimeter of margins is also achieved. So this is post-ablation. What we see is a consolidation or a hemorrhage around it. So this is what. So coming on to the evidence for ablation. So in 2015, this was an Alliance trial, so objective here is a 2-year overall survival, adverse event rate, a local control rate, and pulmonary function test. So so total number of patients were 54 and median age was 76. So 2-year overall survival was around close to 70%. And 2 year local recurrence was around 60%. So 60% benefit, and 1 to 2 year overall survival was around 86% and 70%. So in conclusion, so 2 year overall survival is comparable to SBRT in a similar patient. So this is again in 2018. So similar type of trial, but here they look only at the survival and so in non-small cell lung cancer. So here the mean age was around 71 years, and total number of patients was 42, and overall survival at 1 year and 3 year. 1 year it was 91%, and 3 year it was 60, close to 60%. So most common what came out with this was the tumor less than 2 centimeters are much more favorable with ablation of radiofrequency. So in conclusion, RFA is efficient treatment for non-small cell cancer. It is well tolerated and does not have any effect on the pulmonary function. So this is the most important thing. It does not have any impact on pulmonary function post-procedure as compared to SBRT. So this is when they had compared with surgery, almost overall survival was almost similar with surgery. So what do we infer from these trials? So lung function is preserved. That's the key thing in most of the patients. RFA can be reapplied or can be done if there is local recurrence or if there is residual. Gradual, so over a period of time, there are studies which are evolving over the last 2 decades, and size does play an important role. So if the tumors are between 2 to 3 centimeters, those are an optimal size for doing any good ablation. So coming on to microwave, these outcomes overall survival are similar to RFA, and 3 year overall survival is almost same. Here the size is not the limitation. We can go anywhere from 3 to 5 centimeters. So coming on to this was a paper by Young et al. Which showed local control rate of 96 and 48% at 1 and 5 years, and median overall survival was 47%. So when they had compared RFA with microwave in a retrospective study, what did we achieve? So microwave has definitely higher coagulating necrosis volume as compared to RFA. Microwave requires a smaller time as compared to RFA. There is no heat sink effect and lesser chances of pneumothorax. There is generating evidence for cryoablation. So these are a couple of papers which showed that cryoablation, the local control rate is similar to RFA and microwave. So there is a database from US which compared a thermal ablation with SBRT. Where they had done around close to 28,000 patients. They included all the studies together, and in thermal ablation around 1,000 patients were available in this database, whereas in SBRT around 27,000 patients were there. So overall survival at 1 year and 1 year with SBRT and with thermal ablation is almost equivalent at 1 year, 2 year and 5 year. So in conclusion, overall survival in thermal ablation was non-inferior to stereotactic radiation in 1 month. So coming on to take-home message, ablation is a curative treatment modality. It is safe in patients who have high risk of surgical candidate. It is minimally invasive and low morbidity as compared to surgery. Recurrent and residual lesions can be ablated in case of ablation. Thank you.